Now I invite Dr. Ramjee Mehrotra, the very famous CTVS surgeon, and his topic is very interesting topic, the current status of heart transplantation in India.
Good evening, my colleagues. Thank you, chairpersons. Thank you, Alok, for inviting me, and congratulations for such a fantastic organization. So, with Dr. Pradhan also touching base with heart failure therapies, I would touch base on the treatment, the surgical treatment of end stage heart failure, where everything is failing, cannot be repaired, so you got to replace this one. And they are all causes, but mostly ischemic heart failure patients who come to heart transplant surgery. And when it happened first time in 67, it has come a long way from donor and recipient aspect. So that now you may have heard that xenotransplantation is also being done and people have survived 2-3 months. So this is something to look at also when we think of the paucity of the donors and the huge burden of end-stage heart failure patients which they. Along with that, the mechanical circulatory supports are also chipping in. The artificial heart is also in vicinity to be used as much easy as transplant. So which patients need referral? The guys who cannot be managed with optimized medical treatment, although you must have known with new medicines, the patients who are booked on transplant list, many have been taken away from transplant list. Many patients who are there going back to say Odisha and all that, and when you get a donor, you call them, they say main to cycle chala raha hu. So that is also there, that many people have been taken away from the list. When they came to us, they were being admitted twice, thrice, and we had booked them on the list, and many have been taken away. So these are some of the guidelines that list these patients. Of course, we have to understand that not ejection fraction only defines a candidate for transplant. They should have heart failure symptoms which are not being managed by synchronization therapy, optimized medical treatment and all that. If a person is having ejection fraction 25% and he is well managed, symptom free, or almost say class 2, we would not list them. Along with that, if they have high lung pressures, PA pressures, if they have irreversible end organ disease, especially kidney and liver, those will be contraindication for transplant, but there may be indication for LVAD. Relative contraindications, infection, cancer, obesity, non-compliant patient, non-family support, and all these things will be related, and they are better suited for what we call as mechanical support. So this is the ideal patient. Less than 65 years, good liver, kidney, lung functions, no PAH, and they are not having substance abuse. So these are the checklists that patient go through, but we also have to be mindful that we don't waste time. The irreversible organ damage sets in, and then everything goes haywire. So we have to make sure that the time is utilized to list them, to have all these checklists, but not to waste that. This is a busy slide, but I would say that if we have a heart failure patient, we have mechanical support system. The easiest is IABP, and then we evaluate. Many patients will have repairable lesions, including coronary artery disease, valvular disease, congenital heart disease, and all that. But those guys who have kind of irreversible thing, that's they had chemotherapy, they had genetic problems. So these we know will not have much chances of original heart recovery. So we will get them listed. But if they tip down, if they have heart failure, we'll put them to bed. These are the patients who will be more suited for left ventricular assist device. Previously, we used to compromise on donors. Nowadays, we will take even donor 64 years, say 65, even 70 probably. We may do angiography and all that. But we have less number of donors also still, and we will not try waste any organ. We had very tight criteria to select a donor, but we are compromising because many patients who are dying, they may have what we call as compromised heart, but that may be better from nothing. So this is how we get the heart transported. Nowadays there are perfusion systems which do not put pressure on us to transplant that organ within 4 hours. That's what is called ischemic time. So we can have our own good time. The heart is getting perfused and we can transplant them even 7-8 hours later. These are some of the things. So these are some representation how the heart is taken away. Basically, we cut the aorta, pulmonary artery, SVC, IVC, pulmonary veins. If lung transplant guys are also there, then whole LA is not available to us. IVC may be short, but those things we manage technically when we transplant. This is how we start suturing. So LA is not left-sided, it's posterior. So first the anastomosis is of the left atrium, and then we sew on. When we started heart transplant, the SVC, IVC were not sutured. The RA was sutured. Now we have what we call as bicaval suturing. This is aorta PA. So when it is sutured, it looks like that. These are the ways we increase the donor pool. And nowadays, even 20-25% ejection fraction with PET positive, or I would say the viable myocardium where there is demonstrated. We'll do the CABG with very good results. We will not list them. So there are progress in every branch of cardiology which allows us to have multidisciplinary patient-centric approach to these patients. As I was saying, you can see the xenotransplants, 60 days. So this is also coming. I will touch base now what's happening nowadays, what's our situation. So I would say that we were not behind. You remember 3rd December 67, the first transplant in Cape Town by Christian Bernard. And see, India has gotten good physician from start. P.K. Sen, Bombay. In February 1968, he does the transplant. Only 3 months late. 4th surgeon in the world. But if we say current situation in India, probably we will be happy, but we will be sad also. I'll come to that. So after 68, things were in lull. So this brain death legalization law came into being in 94. I was in All India Institute as first year resident in 94 August when Devi Ram was admitted in that hospital, and we suddenly had, okay, transplant is going on. He was roaming around for 3 months, knew every one of us. And we thought, will he get a transplant? How that is possible? And it was possible. So in OT1 there was recipient, and OT2 there was the donor who came from the neurosurgical department. And this guy lived for more than 10 years. That changed history. Second transplant was done next year by K.M. Cherian in Madras Medical Hospital. But if you see from 94 to 2000, we progressed so slow. We had only 50, 60 donors averaged in 6 hospitals. Transplant heart only 15, only 50 heart transplants. So things were so slow. Why was that? Because the intensivist who is there, who will take care of potential donor, they are not part of the declaration team. The attendants knows them, but they are away. So I think the lack of interest, and you see many government hospitals will not have that system. And it costs money. So rich people, probably so-called rich people, they will get the transplant benefit. So there is dichotomy, donor, recipient and all that. And people will not trained. If you see the absolute donors numbers in the world and transplant, and you see ours, we are still, we can't talk about much. This Mohan Foundation, I was in Bombay. I came back from Harvard in 2003. I was in Bombay, and these guys were doing groundwork. They sensitize physicians, they sensitize public. And I think in Tamil Nadu, these guys have transformed the whole situation. And Tamil Nadu has been still the number one state as far as transplant hearts are concerned. They have very much big role. And how the donor pool is increased, you see, first they will talk about eye donation. Many people are very sensitive. And they will feel the sensitivity. And then they will ask for more organs. So this is called Ramchandra Protocol, and it has been very, very successful. You see, the donors are increasing. The transplant kidney, the liver, the heart, the lungs are increasing. You can see from 15 to say 18 or 20, pre-COVID, the transplants even doubled. But they are those numbers, 200, 250, something like that. That's not for us. We have to do much more than this. You see the hospital list? Many hospitals are listed as a center for transplant. But if you see the map, these are none. This is the main, Karnataka, Maharashtra, Telangana. So those are the bulk hospitals or states doing this. You see, 10% of all organ transplants are heart. So these things sadden you, but the growth which has happened from say 2015 onwards is probably very encouraging, I would say. Results, we're not far behind. 1 year survival, you see, 5 year survival, 75% around, more than 70%. So these are still some of the challenges which I would say, but I think Make in India, the machines, because if heart failure patient is admitted, you're waiting for transplant, and he decompensates, what you do? The mechanical support system also come in, but they're costly. So I think Make in India also is chipping in, which gives us more facilities to treat them, not allow them to die till the time they are waiting for transplant. So if I do LVAD, the guy will be going around, the end organ dysfunction will be taken care of. There'll be lung pressure will come down because lowering the LVDP and all that. They probably will either recover. Out of 4 LVAD in BLK, 2 have been successfully weaned off. Their own hearts recovered. So that's something good about all that. The way forward, I would say, we all should join hand. We should recognize patient that they are decompensating. There's the time to refer them. The multidisciplinary approach, the sensitization, the increased donor pool, increased use of mechanical support in the time is all this thing. I would say that we harp around saying donors are not available. I say that donors are also wasted. Sometimes, as I said, 2 times, my patients dissed me. They didn't come back. No, मैं तो ठीक हूँ. So donor hearts are also getting wasted. This also has to be understood. All these green corridors by police, the IAF, commercial flights, they are all chipping in. They are doing fantastic coordination with transplant teams, and we salute them. So this shows that all doctors, psychiatrists, cardiologists, cardiac failure doctors, surgeons, all and nurses, perfusionists, all are very important. And in one place, जैसे बॉम्बे में म्यूजिक के लिए सब एक साथ थे या फिल्म्स के लिए, that is the main thing. This is the teamwork. It's the easiest operation. but kind of logistics which have to be in place to get the best result out of all that exercise. So I would say that all is not over for these patients. In timely action, appropriate action saves many. And I need help in mnemonic, which sensitizes us. Okay, this guy needs help. So with this, I would again thank you and Alok. And coming to Varanasi is always, always nostalgic. I'm from BHU, and my friends, everyone is here. So I love coming back here, and I'm very emotional, nostalgic. Thank you. Thank you.
Thank you, sir, for a nice presentation. So my question is, what is your experience with the LVAD as destination therapy, and how many of your patients are taken as LVAD as destination therapy?
Is I would say 70, 75-year-old guy who is coming with recurrent heart failure and even has, say, irreversible liver and kidney damage or cardiorenal problems, or these are being managed fantastically nowadays with HeartMate 3. The complication rates, including long-term AR, is also reduced. But the cost probably is something that hinders a large, wide approach to these therapies. The cost is around, say, 1 CR. 85 lakh the machine costs. But people are coming in. People are wanting this. Probably the understanding of having not to come and spend money and time in the hospital. Looking, there are patients who have been, VADed in 2013 or 12. They are coming back. Many of them are in America also with their kids. So this is fantastic therapy. And those are with HeartMate 2. The HeartMate 3 is much, much, much better.
Sir, up to how much time we should wait for to a patient on pharmacological treatment before considering heart transplantation in that patient?
I told you, if they have refractory recurrent VT, if you see the coronary arteries have been grafted before, re-redo, you don't get any targets. If you have very diffuse disease, and you have end-stage heart failure, and with OMT and AICD and all, CRTD, you're not able to manage them. At least 2 times they've come back. I would say more than one. I mean, you recognize during that hospital heart failure treatment that this is the guy who will come back. So I would probably talk to those patients' family. I would sensitize them. I would make sure that these guys understand, because it also takes time to tell them point blank that this is a treatment available and you may need it, rather than sending back home to have a chance that they come back again. Second admission gives them that they will not go to the hospital, higher chance. Coming back again, dying within 1 year, higher chances of that. So you are able to recognize them with all those 4 or 5 pillars, whatever. So
Ramji, hi. I
good
enjoyed
to
your
see
talk.
you. Good to see you.
Good to see you. I really enjoyed your talk. I just have one question. In your view, what do you think is the biggest hurdle in performing orthotopic heart transplantation in India?
Mindset. Mindset. The referral, the, as I said, donation. Many people, the donors, potential donors, are just dying. No, nobody is. And Tamil, if you see Tamil Nadu government's approach even, those guys are, road accident. The guy is there in the hospital. He's a potential donor. There are many things. Suppose I have a recipient. I go to get the heart. कौन जाएगा? पैसा कौन देगा जाने का? अगर मान लो मैंने देखा हार्ट ठीक नहीं है और मैंने बोला बॉस लेना नहीं, खर्चा कौन दे रहा है? Those things have to be taken care of. So this is in the mindset. And somebody has to be very, very passionate to the point of being mad to do this. Bala is an example. But all of us have to understand that things have to be user friendly. You have a duty, all of us. That's why I thought that this is a great opportunity. this is the thing that we recognize the potential recipient. We recognize their shortcomings. If there is no family support, if they are non-compliant, if they are substance abuser, oh, don't waste an organ. Daan hai ye. But also we recognize a potential recipient who will understand the importance of this. I told you Devi Ram, first transplant. I was first year resident. हमें पता नहीं था हार्ट का एज क्या होता है. He was just roaming around 3 months. Knew us by name. And the guy got operated. I was on call on that day. इतनी बड़ी बड़ी थोराटेक मशीन थी हमारे यहाँ. अब तो थोराटेक, I mean, Elvad, you can wear it. When I was on Harvard, we had that small version and we sent them to Fenway Park to have a baseball game watch. So all those have, I mean, industry also has supported. There are things available. Patients are paying. You see liver transplant, you see kidney transplant, you see whatever transplant. They are spending 1 crore. Lung transplant, 1 crore. Heart transplant, 25 lakh. And we are thinking, oh, we are not affording. 25 lakhs. Bombay mein CBG, 25, 40 lakh. So, I mean, these are all mindset. We seeing money. We don't see the life, which is more than money. 40 साल का बंदा बार बार भर्ती हो रहा, मरने को तैयार है. If he gets a transplant or say even VAD, is not it worth it? So it is, I think, in the mindset that we have. In North India, we have to do that, which South India has shown a way. You see, most of the transplants are done in Tamil Nadu heart. Lungs are in Telangana. Why we can't do this? I think we can do this.
So practically, you're saying that we don't have dearth of donors.
I would say,
Yeah.
every
But-
month in Delhi, I know that 2 transplant donors are wastage.
Okay. So then what about the recipients? Do you think that whenever you counsel them for operation or heart transplantation, they all will agree that if you tell them that there is a...
That's what I said. The guy from Odisha said, I am not. So
Exactly,
I
that's what
have
I'm
a
saying.
problem
Yeah.
that, say, one group, I have only 1 patient. So the list has to increase. If I have 1 group, 10 patients waiting, let him not come. Let the other one come. This is how we did in America. This is how they are doing it down there. If there are 2 patients waiting, they will fight with you, they will fight with each other. मैं आ रहा हूँ, मैं आ रहा हूँ.
Yeah,
The organ is not wasted.
problem
वो
over
नहीं
there
बोलेगा
is-
मैं साइकिल चला रहा हूँ.
problem over there is different because they have a dearth of donors, but we have the other problem. Because there was a session in the Jaipur in this transplant meeting. They were saying that the problem is that the recipients, once you tell them and you go through the whole, that information to them, they refuse. They say that I will live with the medication. I will live. Some of them they agree for
We
LVAD.
can't blame them.
They
The
can
medicines
afford.
have come so. You see carvedilol, you see Viriscoa, you see the heart failure. Many are generally taken away from list. We'll take them away. But for 1 patient being taken away, there are 10 patients waiting to be added on. That's what we have to realize. That's what we say. That we have to open our eyes that this is the patient who needs help. So if you have in every, see many hospitals being listed for heart and lung, the government, the inspectors are coming, they will inspect the hospital if everything, kidney transplant is being done everywhere, liver transplant is done. So you have all the logistics in place, वो नहीं बोलेंगे कि आप नहीं कर सकते, they will say do it. So all hospitals are allowed to do this if they have basic facilities. Patients are waiting. आप उनको लिस्ट, अगर बी ग्रुप के मेरे पास 5 पेशेंट हैं, ओ के 5 हैं, बाकी के 5 हैं, एक को मत आने दो ना, दूसरा तो है. बट द प्रॉब्लम इज अगर मेरे पास एक ही ग्रुप का एक है, उसने बोला मैं नहीं आ रहा हूं, बिल्कुल सही है, नहीं आ रहा हूं भाई, साइकिल चला रहा हूं, ठीक है, क्यों ट्रांसप्लांट करना है मेरे को, मुझे भी नहीं करना है. बट वी हैव लिस्ट विच इज शॉर्ट. आप लिस्ट करो, साउथ में जा रहे हैं, आप उनको ट्रांसप्लांट बोलो and they are going to Bala. So that's all. But I would say we all did first case here. मैंने आया तो CABG पहला किया, सबने हम लोगों ने पहला कुछ तो किया होगा. But once you do 2, 3, they're ready to come. They're ready to be with you. They're getting listed. But the referral base has to increase. All of us have to recognize, yes, this is a good therapy, underused therapy. Money is not a problem. It's life, which is to be seen rather than money. People are spending for lung transplant. Lung transplant has worse results than heart. And they are spending money on ECMO. They're waiting on ECMO for 30 days, 25 days. 1.5 करोड़ रुपए लेके तो भी उनका नहीं हो रहा. And they are spending. So I don't think money is a problem. I don't think those are a problem. If we see as doctors, medical providers, the organ should not waste. Organs should be procured. Potential donor में से मुझे लग रहा है 10 में से 2 लोग डोनेट करते हैं. 8 जा रहे. टाइम नहीं है. अभी प्रैक्टिकल प्रॉब्लम बताता हूं. आपने एक डोनर को बता दिया भैया ये आएंगे ऐसे होगा. अब किसी को क्रिमेशन भी करना है. वी हैव टू बी वेरी सेंसिटिव. मैं कहीं से भी आता हूं मैं नमस्ते करके आता हूं उनको, बिकॉज वी हैव टू पे रिस्पेक्ट. वो सबसे बड़ा दान कर रहे हैं. हमने बोला भाई ये तो हो गया, ब्रेन डेथ हो गई, आप डोनेट कर, बिल्कुल डोनेट करेंगे. अब आप देखो क्लॉक क्लिक कर रही, 9 बजे की बात है मान लो, 12 बजे तक आप हार्वेस्ट निकाल लो. क्रिमेशन के लिए भी उनको जाना है, घर में भी ले जाना. अब क्या हो रहा, लिवर वाली टीम आएगी वहां से, ये वाले वो वहां से आएंगे, फलाने यहां से आएंगे. वो 4-5 बजे तक आप बैठ के ताली बजा रहे हो, वो लोग भी ताली बजा रहे हैं. पेशेंट्स के अटेंडेंट बोल बॉस अभी बहुत हो गया, अभी मेरे को जाने दो, मेरे को क्रिमेट करना है. ये भी है, हम लोग देख रहे हैं ना. अब उनकी डिले का खर्चा कौन करे? उसकी जितनी देर हो रही, आईसीयू में ट्रीटमेंट भी चल रहा है. प्राइवेट हॉस्पिटल में तो वो तो फ्री तो नहीं होगा. किससे पैसा मांगोगे? वो कहेंगे डेड बॉडी को रख के हमारा तो पैसा लूट रहे. दिस इज ऑल्सो ट्रू. So these are some practical problems which I didn't enumerate, but I'm glad you asked. These are the practical problems. अगले दिन क्रिमेट नहीं करेगा बॉस, और हमें बहुत सेंसिटिव होना चाहिए. उनके ऑर्गन्स दे रहा, घर वाले रोते रोते डोनेट कर रहे हैं. हम कह रहे लीवर वाले वहां से कलकत्ता से आएंगे, अभी वो उनकी फ्लाइट डिले हो गई, अभी ये हो गया. 9 बजे जब कभी होता है ना तो 10 बजे हम हार्वेस्ट नहीं कर पाते, हम शाम को 6 बजे हार्वेस्ट कर रहे होते. फिर रात में तुम ट्रांसप्लांट कर रहे हो, तुम्हारी लिस्ट गई. I mean, those things are very important. We have to understand that somebody is there donating, and they need more respect than anybody else. तमिलनाडु में वो गवर्नमेंट भी कर रही, वो भी कर रहे, प्रशासन भी कर रहा है. हमारे यहाँ तो सब कर सकते हैं, हम भी कर सकते हैं.
Dr. Mehrotra, we have very short time, huh? So you are requested to please end the session here. Your talk.
Thank you. Thank you.
Thank you, sir.